Next, we move on to talk about the clinical evaluation of a seizure. And the first thing we need to identify is, was it truly a seizure? So that's part of the workup to rule out other differentials that may mimic a seizure. And the second is that if it was a seizure, was it provoked or unprovoked? So to determine whether or not it was truly a seizure, we can assess it based on the clinical features, the characteristics of seizures, and also from collateral and witness information. So the clinical features will depend on the type of seizure, whether it is focal or generalized. Focal seizures can have auras, and focal seizures and generalized seizures can have some sort of impaired consciousness. So they have an altered mental status. They can have loss of consciousness, decreased responsiveness, or behavioral arrests. Then we look at symptoms that can occur during the seizures, such as automatisms and auras, tongue biting and incontinence and cyanosis for generalized seizures. And a specific finding for tongue biting is that the tongue biting is usually lateral on the tongue. We also need to ask them about any prior symptoms that may have been unrecognized seizures, such as any unresponsive staring, any quick isolated body movements that may indicate myoclonus, any unexplained nocturnal tongue biting or incontinence, any olfactory or gustatory hallucinations such as temporal lobe epilepsy, and any sense of brief fear, anxiety or panic, or any visual hallucinations. So these are the auras that we were talking about. It is important to also ask them about the post-ictal period, because there is a transition from the ictal seizure state back to the pre-seizure baseline, and this is the post-ictal phase. And sometimes the post-ictal period may be the obvious presenting feature if the seizure was brief, subtle, or unwitnessed. Common manifestations of post-ictal periods will be confusion and suppressed alertness. You can have focal neurological deficits such as thought paralysis, where you get weakness of a hand or an arm or a leg, and this occurs after a motor seizure on one side of the body. And other focal symptoms will depend on the seizure location, as mentioned before. The post-ictal period can range from a few seconds to hours depending on the brain regions that were affected, how long the seizure went for, if the patient received any medications that may terminate the seizure early on, and the patient's age. So for example, young adults with frontal lobe focal seizures may have post-ictal phases lasting seconds, whereas older adults with secondarily generalized seizures may have confusion lasting hours to days, especially if they have underlying brain dysfunction or a tumor. But most patients generally will begin recovering within half an hour of a generalized seizure. The next is characteristics of a seizure. So seizures are usually brief, episodic, and stereotypical events lasting less than 2 to 3 minutes. So if they keep happening, they will happen usually in the same manner over and over again. More prolonged symptoms, so not brief, may indicate other differentials such as migraines, a stroke, and psychogenic non-epileptic seizures. And the seizures signs and symptoms typically have a very clear and sudden onset. The next, once we are satisfied that the patient actually has a seizure, is to identify whether the seizure was provoked or unprovoked. And so we need to identify whether a precipitant or a trigger occurred immediately before the seizure. The majority of patients with epilepsy will have no identifiable or consistent trigger, and triggers are the sole cause of seizures in only a small minority of patients. So most seizures are unprovoked. Triggers may precipitate non-epileptic paroxysmal disorders, especially syncope, and this can make it hard to differentiate with other causes because the triggers can lead to syncope, and the triggers can also lead to psychogenic non-epileptic seizures, and triggers can also lead to seizures. So what are the common triggers? So common triggers which are experienced immediately before the seizure are things like strong emotions, intense exercise, loud music, as well as flashing lights. There are also other physiological conditions or non-physiological conditions that can lower the seizure threshold, such as fever or a current illness, menstrual period, sleep deprivation, pregnancy, stress, and alcohol use. We then ask the patient their background history, including a past medical history, which covers their birth and developmental history, and any previous history of neurological disorders, such as any CNS infections like meningitis, any history of stroke, structural brain disease, or any head injuries in the past. We also want to identify if they have any chronic medical conditions that could cause metabolic disturbance that may lead to a seizure, such as diabetes, chronic kidney disease, cirrhosis of the liver, and thyroid disease. We also want to take a thorough medication history to identify any possible complicit medications that may lower the patient's seizure threshold. And with family history, we want to identify any family history of epilepsy or seizures, because a family history of such will increase the likelihood of the patient having a genetic epilepsy syndrome. And for social history, important to identify any recreational drug use as well as any alcohol use, including alcohol withdrawal. For the physical exam, we want to have a general inspection as to how the patient looks, whether they are well or unwell. We want to look at their vital signs and perform a neurological examination to identify mainly any focal signs that might indicate them having a stroke, because that is a medical emergency. And we also want to assess for any signs of any injury from the seizure, such as any lateral tongue bites, any bruises, any lacerations, and any fractures. The next step of the evaluation are investigations. So all patients with a seizure should have a 12-lead ECG, and this is to investigate any potential cardiac causes as a differential, in particular cardiogenic syncope. We also should do an EEG, an electroencephalogram, in all patients with a first unprovoked seizure, and this is because it helps with classifying seizures and the epilepsy type, so helping with diagnosis. It also helps predict the risk of seizure recurrence, which is very important for prognostication of the patient's seizures. And the diagnostic yield for an EEG is highest if performed within 24 hours of the seizure, though this may not always be practically possible. And on focal epilepsies, the EEG findings are focal epileptiform discharges, whereas for generalized epilepsy, it will show a generalized spike and wave discharge pattern. Neuroimaging should also be done in all patients with a first suspected seizure, and the neuroimaging can be urgent or non-urgent. Urgent neuroimaging will be done if the patient has any focal neurological deficits, including any focal onset seizures, and this is to mainly make sure the patient hasn't had a bleed or a stroke. If they have a persistent altered mental state, fever that may indicate infection, a persistent headache, a recent history of a traumatic head injury, malignancy, or if they have a bleeding tendency such as being on anticoagulation. If urgent neuroimaging is indicated, then a non-contrast CT is usually the imaging modality of choice due to ease of access, but a CT is less sensitive than an MRI. CT can identify bleeds and large tumors or calcified lesions, but for more smaller and niche lesions may not be picked up on on a CT. If the neuroimaging is non-urgent, then an outpatient MRI brain can be organized for patients when they have returned to their neurological baseline. And MRIs are better at picking up infarcts and tumors, as well as scarring or any cortical dysplasia. And the MRI is also better at demonstrating temporal lobe anatomy than CT. And we know from previously that there are several types of temporal lobe epilepsies. It is always important to correlate the MRI findings with the clinical and EEG information, and this is because although a structural lesion usually suggests a cause for the seizure, many may be incidental. So for example, if the patient has a focal seizure, which indicates that the findings are on the right side of the brain, but when you do an MRI, they have a left-sided tumor, we need to correlate to make sure that the left-sided tumor is actually relevant for the patient's symptoms that indicate a right-sided cause. Next will be pathology testing, and this is to investigate any provoking causes of the seizure. So blood glucose to look for hypo or hyperglycemia, UEC and CMP to look for renal function, such as in chronic kidney disease and any electrolyte abnormalities. We also do a VBG and a lactate, and an elevated lactate in the first 2 hours after the event suggests usually a seizure rather than a syncope or a psychogenic non-epileptic seizure. However, a normal lactate does not rule out seizures. We also do an FPE to look for anemia and signs of infection, LFTs for cirrhosis, TFTs for hyperthyroidism, and we can do a tox screen if it's clinically suspected, or a lumbar puncture if this is also clinically suspected for meningitis, encephalitis, or a subarachnoid hemorrhage. Again, with an EEG, it helps to diagnose more subtle seizures, and it can be arranged on an outpatient basis for patients who have returned to baseline. And we can combine EEGs with particular maneuvers to help increase the yield, such as sleep deprivation or hyperventilation or photic stimulation, to try and identify whether or not the patient may have seizures or epilepsies that are triggered by these particular maneuvers. In adults, after a first seizure, an EEG demonstrates epileptiform abnormalities in 25% of cases, and this indicates an increased risk of a second seizure in the next 2 years. It is important to note, however, that a normal EEG does not rule out epilepsy, and that the EEG should always be correlated to the patient's clinical and imaging findings. So the next, we'll be going through differential diagnoses that may mimic a seizure and what are the differentiating clinical features that may separate them apart. So the examples that we'll cover will be syncope, fall of head injury such as a concussion, stroke and TIA, psychogenic non-epileptic seizures, and migraines. Hypoglycemia is obviously another differential for seizures, but that can be easily identified with a blood sugar test, which every patient with an altered mental status or a suspected seizure should have anyways. So let's first identify features that suggest a seizure. So the pre-ictal or aura features would be focal symptoms, so such as epigastric rising sensations is suggestive of temporal lobe seizures. You can have olfactory or gustatory hallucinations, which are specific for focal seizures. A sense of déjà vu, especially prolonged déjà vu, is specific for seizures. And indescribable sensations, so if the patient often struggles to articulate the aura that they're experiencing, you should think of them possibly having a seizure. Features during the seizure phase itself is that seizures are typically stereotypical. So they are usually always the same within an individual patient. They will occur over different periods in time. So during the seizure, seizures are usually very stereotypical. So they tend to occur in the same way within the same individual patient. And if it's a tonic-clonic seizure, they will have a tonic phase followed by a clonic phase, and they can have apnea, cyanosis, and incontinence. Lateral tongue biting is quite a specific feature for seizures, and the duration is typically around 1 to 2 or 3 minutes. Post-ictally is what helps to separate seizures from a lot of other conditions where they can have a post-ictal confusion or lethargy. They may also have muscle aches and tiredness and thought paresis, which is a transient focal weakness following a focal seizure, as we mentioned before. And for generalized seizures with impaired consciousness or focal seizures with impaired awareness, the patient will typically be amnestic for the event, so they won't remember what happened. Features that suggest a syncope will be things like they usually have a prodrome, so a prodrome where they feel lightheaded or sweaty, and they may have dimming of their vision or tunnel visioning, although it is important to note that cardiac syncope typically does not have a prodrome, so it occurs with a sudden onset loss of consciousness. And in contrast with seizures, they don't have prodromes, but rather they have auras, or they go straight into a tonic-clonic seizure. In syncope, the loss of consciousness is brief, usually less than a minute, and the patient recovers quite rapidly without any post-ictal confusion. In contrast, seizures they're also brief, but they tend to last a little bit longer than a syncopal event, and they have a delayed recovery with post-ictal confusion. There are certain triggers that are characteristics for syncope, such as orthostatic syncope, micturition syncope, or vasovagal syncope, such as the sight of blood or stress or dehydration. Whereas the triggers for syncope that we mentioned before usually don't cause seizures. Myoclonic jerks in syncope can also occur, but these are typically brief and irregular and asynchronous, whereas the myoclonic jerks in seizures are typically more regular and synchronous in nature. And in syncope, there is typically no lateral tongue biting, whereas lateral tongue biting is more specific for seizures. Features that suggest a TIA rather than a seizure is that TIAs or stroke tends to have negative symptoms, so they tend to have a loss of function or neurological deficits, such as sensory loss, weakness, and visual field loss. By contrast, seizures tend to have positive symptoms, so where you get sensory loss in strokes, you'll get tingling in seizures, muscle weakness in strokes, you'll get jerking of the muscles in seizures, and in visual field loss in strokes, you'll get visual flashes in seizures. With strokes and TIA, the onset is most intense at the start of the episode. So when you have a blood clot or a bleed, you're going to have most of the neurological deficits occurring at the start, because the blood flow will be immediately cut off. Whereas with a seizure, the symptoms will start typically in one area of the brain if it's focal, and then spread to other areas of the brain. And if it's a generalized tonic-clonic seizure, then that is very easily distinguishable from a stroke, because strokes don't tend to have tonic and clonic jerks. And in seizures, the symptoms may spread or march. And in strokes and TIAs, there usually is no loss of consciousness and no post-ictal confusion, whereas in seizures, they can have loss of consciousness and post-ictal confusion. What about psychogenic non-epileptic seizures or pseudo-seizures or functional seizures? These tend to be prolonged, lasting tens of minutes, whereas seizures are usually brief, lasting less than 2 to 3 minutes. And the course of PNES is typically fluctuating in nature, where it waxes and wanes in intensity, whereas with seizures, they tend to be stereotypical and consistent, and they don't go up and down in severity during the episode itself. The episodes for PNES evolve significantly over time, and so one day they may have symptoms such as XYZ, and other days they may have symptoms ABC, and so it will change over time. Whereas in seizures, the episodes will typically remain consistent over time. ABC day 1, ABC day 2, ABC day 3. The symptoms of PNES is highly variable, and so you will have certain features that usually will not be present in seizures, such as eye closures and side-to-side head or body shaking. The limb movements will be typically asynchronous and variable, and there can be changing movements during the same event itself, as we mentioned before. Whereas with seizures, the symptoms are typically very consistent of the auras or the tonic-clonic or myoclonic jerks that we touched on before. If the patient has a whole body shaking episode, that would indicate a tonic-clonic seizure, but they are able to have a partial recall of the episode, then that is not consistent with a generalized seizure, because if you have a whole body shaking, that indicates a generalized tonic-clonic seizure, and you expect there to be no recall of the event. A useful tool or investigation to help differentiate PNES and seizures will be ambulatory home video EEG monitoring. So that's where we combine EEG with video monitoring, and this will help to differentiate between epileptic and non-epileptic seizures. So for example, if you have multiple events clinically captured on video that may look like a seizure, but there is no corresponding epileptiform activity on EEG, and the clinical features, as we mentioned before, are not consistent with an epileptic seizure, then this confirms the diagnosis of functional seizures or psychogenic non-epileptic seizures. That is, the absence of ictal EEG changes during multiple typical events with unresponsiveness or whole body shaking is diagnostic of functional dissociative seizures. Next will be migraine with aura, and the main differentiating factor will be the rate of symptom evolution. With migraines, with auras associated with migraines, these tend to develop slowly over more than 5 minutes, whereas the auras in seizures typically develop rapidly over seconds, because we mentioned that the onset of seizures are very clear and sudden. There's also differences with visual symptoms. If the aura for migraine has visual auras, the visual aura in migraines tend to be in black and white, and they have linear patterns, whereas the auras in seizures tend to be multicolored and circular patterns. And migraines, the auras can have a positive to negative sequence. So you have a positive phenomena such as scintillations, which are flashing lights, which will then be followed by a negative phenomena such as scotoma, which are blind spots in your vision. Whereas in seizures, it is positive phenomena throughout. If you have a headache immediately after the aura, and the headache is typical for migraine, so unilateral throbbing, then that is more consistent with a migraine. Whereas with seizures, they typically don't have any headaches after the aura, although headaches can sometimes occur in the post-ictal phase, although this is a less common manifestation. Other features that are more indicative of a migraine will be things like no loss of consciousness, there is no post-ictal confusion, the presence of severe nausea and vomiting, as well as photo and phonophobia. Whereas in seizures, they typically have a loss of consciousness, there is some post-ictal state, there is typically no vomiting, and there is no photo or phonophobia. And the last one is concussion. So with a concussion, the main differentiating feature with a seizure is that in a concussion, you will first have the fall and then the loss of consciousness. Whereas with seizures, you will first have the loss of consciousness and then the fall. So it's important to clarify the history with either the patient or collateral witnesses to understand whether or not the fall or the loss of consciousness happened first. If there are convulsions, then for a concussive convulsions, these typically occur immediately after the blow, within seconds to minutes. However, convulsions that indicate seizures will happen minutes to hours after the blow. So the blow is quite distinct temporally in time to the convulsions. In concussions, the recovery in the acute phase is not as long, whereas in seizures, as we know, there is post-ictal confusion, which means that the recovery can take longer. And if there is a tongue biting from a fall, for example, the patient falls down and they bang on their chin, the tongue bite is usually anterior, whereas in seizures, the tongue biting is lateral.